Okay, I am going to get started. It is 12, so good afternoon and welcome to today's Washington Patient Safety Coalition webinar. I'm Kinsey Gray, the Program Coordinator for the Washington Patient Safety Coalition. Before we begin, I have just a few quick announcements. NCWAC will accept attendance at this webinar session as a CE event. To receive credit, you just need to document your time and submit a short survey. You'll receive an email tomorrow with a link to this survey along with today's presentation slides. Please remember that if you want a certificate for a credit hour, you must provide either an RN license number or your equivalent ID number and complete the survey by end of day Tuesday, October 1st. If you have any questions about this, please contact the NCWAC directly. You all are on mute throughout this webinar until we get to the end. Today's speakers would love your participation in a Q&A discussion. So if you do have comments and questions, please type them into your chat box, and then I will use them to facilitate a Q&A session at the very end. Today's speakers declare no affiliation with or financial interest in a commercial organization that could pose a conflict of interest with the educational content of this program. And now I'm pleased to welcome today's speakers, Jenny Weir and Emily Transu. Jenny Weir has a background in health policy, health services, delivery research, and clinical practice change. She currently directs the Washington State-based Dr. Robert Bree Collaborative, bringing diverse stakeholders together to improve healthcare quality, outcomes, and affordability. She has a master's degree in public health from the University of Washington, is a member of the board of the Washington State Public Health Association, and seeks to strengthen the relationship between public health and healthcare delivery. Emily Transu, MD, MHA, FACP, is the Associate Medical Director for the Washington State Healthcare Authority. She received her BS from Yale University, MD from Dartmouth Medical School, and Master of Health Administration from the University of Washington. She's a general internist who practiced for 15 years as a primary care provider before shifting to roles in leadership and management. She is the author of 2 books, On Call and Patient by Patient, about the experience of practicing medicine. At the Healthcare Authority, her role includes clinical leadership of the Employee and Retiree Benefits Division, oversight of the Shared Decision-Making Program, and supporting the work of Healthier Washington and the Medicaid Transformation Project. And now I'll turn it over to them to begin this webinar.
Thank you, Kinsey. This is Jenny Weir, Director of the Bree Collaborative, and we are happy to be here to talk to you about our shared decision-making work. So I'll give a little bit of a background on the Bree to just give context to the work that we're doing. So we are a public-private group in Washington State. We were formed by our state legislature in 2011 to improve healthcare quality, outcomes, and affordability. And our state has really focused on improving appropriateness and patient-centeredness of healthcare for many decades. And our work is really a continuation of some earlier efforts with an expanded scope. So we are named after Dr. Robert Bree, who was a radiologist at Harborview and a leader in some of that earlier work in pushing for more appropriate use of advanced imaging. So the Bree is really a forum to impact change, and we do this through convening and using a standardized process on different healthcare areas. We have 22 members who are appointed by our governor, and they represent different healthcare sectors, so health plans, healthcare purchasers, both public and private, including the Healthcare Authority, delivery systems and hospitals, and quality improvement organizations. So every year, our members select 4 or 5 healthcare services that have a high degree of variation in delivery or variation in outcomes that may indicate waste, that have a high amount of over or underuse, or a patient safety or an equity issue that our community really wants to come together and do something about, but doesn't necessarily have an alternative mechanism. So our recommendations are developed in clinical communities or work groups, and this collection of volunteers will meet for about 9 to 12 months. And our work is really meant to be ground up. It's developed by clinicians for clinicians, and it's not the state or other bodies telling anyone what to do. They are just 1/22nd of a voice at our table. And in our work groups, we review published literature, guidelines from specialty societies, the work of other quality improvement organizations, national entities, and then programs and policies within our own delivery system, so bright spots across the state. Our primary implementation pathway is through our state Medicaid agency, the HCA, and they are meant to incorporate our recommendations into purchasing contracts. So outside of this public purchasing, we can't mandate adoption or set healthcare prices, and so we do a lot of convening and outreach. We've worked on a wide variety of topic areas, starting with appropriateness of C-sections, to increasing advanced care planning for end-of-life care, to opioid prescribing, to developing some bundled payment models to move towards value-based payment. And a lot of our previous work touches on shared decision-making, and you'll see that in C-section recommendations, our recommendations around prostate cancer screening, and it's specifically called out as a mechanism for change in the legislation that created the Bree. But our members also wanted a specific focus on the shared competencies and implementation pathways that really support shared decision-making broadly, and so we selected it as one of our priority focus areas for 2019. And our work group has met since January to define, to prioritize, to look at barriers and facilitators to adoption of shared decision-making, to really figure out a way to make this happen broadly across the state. So now I will turn it over to Dr. Emily Transu, our workgroup chair, to give an overview of shared decision-making, including our hard-won definitions and the healthcare authority's role.
Thanks so much, Jenny. This is Emily Transu. I'm the Associate Medical Director at the Healthcare Authority, which is the cabinet agency that oversees Medicaid and public employee benefits. I will apologize for my voice. I'm getting over a cold, so there may be a little coughing in here, so forgive me. So what is shared decision-making? This is one of the standard definitions, a process in which clinicians and patients work together to make decisions and select tests, treatments, or care plans based on clinical evidence that balances risk and expected outcomes with patient preferences and values. So there's a whole lot in there that we're going to kind of unpack a little bit in the next hour. We'll go on to the next slide. So don't providers already do this? And honestly, this is one of the biggest barriers to this work, is that providers really believe that they do. You know, I'm a good communicator. Of course I share decisions. And I'll say, as somebody who was a primary care doc for 20 years, I kind of fell in this category too. Of course I do this. But then as you really get into a deeper discussion of what it is and how it works, people realize that they actually haven't been doing it as well as they could be or should be. We'll go on to the next slide. So really good shared decision-making involves some specific skills and practices. It's really systematic, and I think of this as the difference between, you know, a naturally gifted runner versus really training for a race. You can learn a lot to make you more consistent and more effective in doing this, and there's some very specific components. Those include reviewing all the available options, eliciting the patient's values, and really helping them think about the implications of their choice in light of those options. And sharing control, which is something that even good docs are not necessarily as good at as we like to think. We'll go on to the next slide. So what isn't shared decision-making? Certainly the sign here approach, and I think we've all probably encountered this at some point in healthcare. You know, here's your consent, please sign on the dotted line. Clearly that's not shared decision-making, but also saying, you know, I would do this, which can be very powerful for a clinician to say, I think this is the right choice. And sometimes that's helpful, but this is a really different thing that's looking at maybe there's something about you and your preferences that would lead you to a different option. Isn't all good provider communication shared decision-making? This is something that we work through a lot in the work group, and we'll go on to the next slide. This is a graphic that I just love, and credit to Jenny who developed this. There are a lot of of components of good provider-patient communication, and some of them will be familiar to you on the phone. So motivational interviewing, for example, which is really focused on behavioral change. Say, you're my patient, you want to quit smoking, or maybe you don't, and I think you should quit smoking. I really am going to want to figure out what are the things that motivate and drive you, and how can I really harness those? How can we harness those together to move your behavior in a healthier direction? Informed consent is really you need to know what you're getting into. So I fell off a trapeze some years ago and landed with my arm pointing in a very unfortunate direction. I needed surgery. I needed to know the risks of surgery before I had it done, but that's not really a shared conversation. There's no question about what the right answer is. Where shared decision-making fits in a really special way is in cases where there's more than one right answer, but those different options have different implications for the patient, and it's really going to depend on the patient's values what the right thing to do is. So there's a lot of overlap, as you can see in this diagram, and a lot of the skills that a doc uses are similar in terms of good communication, information sharing, eliciting the values of the patient, but you're using them for a different reason. And what's really special about shared decision-making is really the final control of that decision very, very much belongs with the patient. Next slide. Another great graphic from Ginny. When do you want to use this versus something else? So as I said, it's the right thing to do when there's more than one right option. Sometimes there's a lot of evidence that you shouldn't be doing something. If someone comes in to see me for a cold and thinks they need an antibiotic, we're not going to share that decision. The answer should be no, and I want to explain why that is. But it's not a balanced option. And likewise, if it's really clear what the right answer is, say with my broken arm, or if you're thinking about whether to get a measles vaccine in the midst of an epidemic, there's a right answer. The patient, of course, makes the final choice, but the discussion is really geared toward trying to move them in a specific direction. Shared decision-making is special because it's really in that midpoint, and it's a unique set of skills. On to the next slide. So fundamentally, this happens in what we call preference-sensitive conditions, more than one right answer, or there's just a lot of uncertainty about all of the possibilities. And in both of those settings, helping the patient make a choice that's really congruent with their values is critical. Next slide. Some of the components of that discussion: ensuring that the patient really understands the medical condition, understands all the options and their risks and benefits, exploring their values and how their different choices would connect with those values, sharing the decision, and then of course there's a component of confirming that decision, addressing the questions, and the documents to document the visit as well. Next slide. Making this a little bit more real. To use a couple of examples of times when this comes up. So total joint replacements. You never have to have a knee replacement, and there's never a specific moment where last week you didn't need it and now you do. Some people are much more tolerant of pain than others. Some people have certain activities that are really important to them that will push them in a direction. Some people are tolerant of a slow recovery and of feeling worse for a while before they feel better, and some aren't. So those are the kinds of values that we think about. I had an elderly patient once who had some spine issues and was really interested in surgery. And I have to say, I was really concerned because spine surgery in particular can be a little bit of a roll of the dice. Some people get better, a number of people don't, or even get worse after surgery. His pain levels were not severe, and candidly, I didn't totally understand why he was considering taking these risks. But as we really talked through it, it turned out that I had not known that he was a ballroom dancer. And this was something that he was still very active with in his 70s. And because of his spine, he couldn't dance anymore. And that was the single thing in his life that he felt the most joy in, and that also really connected him to people and to a community. And essentially to him, just about any risk was worth it to him to be able to get that activity back. So he had the surgery, he actually had some complications and a slow recovery, ultimately was able to dance again, which was fantastic. And there was a point along the way where he had an infection after the surgery and was pretty close to death. And as we talked about it later, he told me that he was okay with that. And that if that had been the outcome, it would have been worth it to him to have had the possibility of recovering. And that's the kind of case that we're talking about here. Somebody else might have made a really different decision. I've had people who wanted more than anything to see their grandchild graduate, and nothing that would have a risk of interfering with that would be worth it to them. They'll go in a wheelchair, but they don't want to miss it. That can lead you to a really different choice. So that's the kind of thing we're talking about in this work. Doesn't have to be as big as a surgery. This can be relevant when you're taking a medication. When I'm putting someone on a statin for their cholesterol, there's a little bit of an increase in the diabetes risk, but a lower heart attack risk. Those kinds of balances are something you would talk about in a shared decision-making conversation. Prostate cancer screening and treatment, another classic example. This is something where there might be a low risk of dying if somebody undergoes treatment for an early prostate cancer, but there could also be a significantly increased risk of incontinence and sexual dysfunction. Different people are going to make really different decisions when faced with those kinds of choices. End-of-life care, perhaps the most significant of all in this, really a place where somebody's values are going to determine what's right for them, and that can be very different for different people. Next slide. So why is shared decision-making important? There's been a lot of research in shared decision-making over the last probably 30 years. And a number of impacts have been shown from using this. It can really improve the patient experience, which is unsurprising. It can actually improve health outcomes as well. It reduces variation and health disparities. And I want to pause on this one because this is one of the things that I think makes this really particularly important. So if you look at areas where certain populations overuse services and other populations underuse them, for example, the use of joint replacement in African Americans is much lower than for other populations, and it's probably too low. In certain Caucasian populations, it's probably a little bit higher than it should be. And there's studies saying that if you systematically implement shared decision-making and really put the choice into people's hands, that variation evens out. So I think there's a real opportunity to impact health equity with this work. Likewise, it improves appropriateness of utilization and spending, and those are carefully chosen words. You don't necessarily save money with this kind of implementation. In general, the more say people have in the choice, the likelihood is that they will decrease a little bit their aggressiveness in what they choose, but not always. And I think this really needs to be thought of as a way to improve quality, improve safety, and not for its impact on spending. Certainly, this is an important part as we are transitioning to value-based care and population health, a really important part of supporting those strategies. Most of the studies around shared decision-making involve the use of a patient decision aid, and we're going to talk a little bit more about those. A decision aid can take many forms. Sometimes it's a single piece of paper, sometimes it's an hour-long video, lots of ways that it can be presented, but essentially they're tools that serve to provide information to the patient, really elicit their values, and help to structure the conversation that they have with the provider. Next slide. Washington State has been very, very active in shared decision-making. We had foundational legislation that was connected actually to the legislation that created the Bree Collaborative that creates some additional legal protections for providers who do share decision-making with a certified aide. And essentially, that means the burden of proof shifts. Normally, if a patient is suing from an outcome saying that they didn't know the risks, the burden is on the provider to show that they did explain the risks, and this flips that over. I would say this is not a strong driver in why people do share decision-making, but it's kind of a nice bonus that there is some additional legal protection that goes along with it. I mentioned that these need to be certified aides, and the healthcare authority certifies aides for quality. We do that via review panels that assess aides based on a number of criteria, and we're going to go through those. We also have a scientific review by subject matter experts. Next slide. I won't go through all the criteria in detail, but I think they're useful because they also help you think about what the components are of shared decision-making. So we need to describe the condition, explicitly describe the decision, talk about, the audience, who does this apply to? What are the options with positive and negative features? Go to the next slide. And then values, and this is one of the places that in our certification work we spend the most time. The certification criteria allow a couple different ways to do that. One is explicitly, here, rate what matters more to you, short-term pain relief versus long-term, the possibility of a surgical complication versus, et cetera. Or they can do it by really helping the patient to imagine what their life would be like if they chose each of the options. So for example, some will do video interviews with people who have had a hip replacement about what their experience was like, or someone else who thought about it, decided to live with the pain and what that's been like for them. So a couple different ways that this can be done, but it's a really important component of a good aid. Next slide. Other criteria, it needs to be possible to compare the features of the options. There needs to be balance, some requirements around statistics if they're used, some information about the credentials of the developer and whether they have conflicts of interest. And then there's a number of specific criteria for screening tests around how that information is presented. Next slide. I will hand back to Ginny to talk more about the work of the workgroup.
Thank you. So we've talked a little bit about why shared decision-making matters, what it is, and how Washington State has a kind of somewhat special environment for encouraging use of shared decision-making. And this was really the reason why our members decided to prioritize this. So it's really seen as a mechanism to achieve our overarching goals of quality, better outcomes, affordability, and equity, and came to us because I think we really have a unique role to set a community standard of care across our state and then work with these diverse community organizations to really foster broad use. So these are our workgroup members, our dedicated volunteers, and thank you very much to all of them. And they came to the table because they've been impacted by shared decision-making in a variety of ways. Either they've used it, they have had outcomes in which they wished it had been used, but they're really focused on making sure that everyone gets access to high-quality conversations about their health when it is appropriate in a shared decision-making context, no matter where they receive care. And I think one of our real value adds at the Bree Collaborative is being able to bring together these representatives from often competing delivery systems and then different sectors, the health plans, the hospitals, primary care, to develop these shared solutions that really can work for everybody and that we can get buy-in for everybody. So we developed 4 focus areas to frame our collective impact. a shared understanding of the definition and the benefit of shared decision making. And Emily talked about that. You can see it in those infographics. The way that we talk about this, I think, really matters because people often think they're already doing this. Developing 10 priority areas as an initial focus for our healthcare community, and I'll talk about those a little bit later. Recommending a highly reliable implementation framework that's customized to an individual organization, and then really talking about how this can happen and how you know this would happen. So that documentation, that coding, and then that reimbursement piece that are so important to support broad use, that are that pathway to make it happen. So our workgroup goal is statewide movement towards greater use of shared decision making in clinical practice at a care delivery site and organizational level. So this means that everybody is moving towards greater adoption, and we use the stages of change framework. So there's pre-contemplation, contemplation, preparation, action, and maintenance framework to talk about what this looks like. So some locations may be in this pre-contemplation phase, so they're just starting to talk about this at a leadership level, while others are really ready to start action. So they might be wanting to have a pilot of shared decision-making in one area, like C-section appropriateness, while others will be maintaining work they've already done or learning from areas and spreading to others. So we wanted to have a framework that's applicable to the wide variety of systems across the state. And we talk a lot about drivers of shared decision-making implementation, so breaking down these mechanisms that will support use. And we want this push to come from multiple departments, multiple types of people. And it really, of course, starts with education and training for providers, either in medical school or doing continuing medical education, making sure that patient decision aids are available, that they're usable, that they're evidence-based, that people trust the aids will actually help in this conversation. And they need to be current, they need to be up to date. Patients and family members really need to understand why this is happening and how shared decision making affects them and what these conversations feel like. And they really need to be engaged in the conversation. And then at a systems level, culture really needs to support these conversations. So starting with that engaged leadership, team members need to have clarity and consistent in how they are expected to engage with shared decision making. And then of course there are those tracking and reporting needs that need to be clear and consistent. Aids need to be incorporated into a care pathway and not feel like a burden, and reimbursement really needs to facilitate the use of these conversations, especially as they might take more time. So these are our 10 priority areas, and we tried to align these with previous Bree collaborative topics. So you'll see a lot of familiar areas here. And we separated them into 4 categories that we think will facilitate adoption, since there are some shared competencies across the areas. So those that are focused on surgical procedures, advanced care planning, those that are focused on screening, and then those under behavioral health. And so some of these have already seen wide adoption. Shared decision-making in a pathway for knee and hip replacement, for example, is utilized by many different delivery systems, while something like a shared decision-making for opioid use disorder treatment is an area that we've heard from our clinical champions is really needed, but there aren't any aids in this area that are really widely used. So we have a wide variety, some that are wanting to spread known processes and others to incentivize the development of the aids themselves. So we also talk about this highly reliable implementation framework. So there are multiple ways to work towards adoption for shared decision making, and they all share common components, really starting with engaged leadership as a necessary first step. So we don't mandate a specific framework, since some have been used by systems and been used well. We don't want to step on any toes there. But I will call out two frameworks here, and when we send the slides around, the underlined text takes you to the web pages. The National Quality Partners Playbook, it's a comprehensive, pragmatic framework to move towards shared decision making, and it breaks these fundamentals into basic, intermediate, and advanced steps for healthcare organizations. And I think that really fits well into the stages of change framework. So they have recommendations around leadership and culture, patient education and engagement, healthcare team knowledge and training, action and implementation, tracking, monitoring, and reporting, which comes up again and again, and then accountability. So a really great framework to move towards this adoption. And similarly, the Agency for Healthcare Research and Policy has the SHARE approach. So that is seek, help, access, reach, and evaluate. And that also is a great framework that has a series of steps that are very reliable, and there has been some training across our state in that model too. And of course, there are others. We just call out these two as the more highly vetted. The documentation, coding, and reimbursement was a huge part of our conversations in the work group, and a huge way that we want to see shared decision-making increase. There are currently codes that can support shared decision-making. Our goal is really for this to be documented like any other clinical encounter, and we do talk about how development and use of additional coding could and should happen. So we also make recommendations to health plans and healthcare purchasers about other mechanisms to incentivize use of shared decision making. So incorporating requirements, standards for value-based models like centers of excellence. We talk a lot about metrics, and we list metrics that aren't necessarily required but that are suggested. We talk about how to incorporate shared decision-making as a component of prior authorization for high-risk, high-cost approaches to preference-sensitive conditions. So a lot of different pathways, and we really tried to break this out and focus on this implementation from many different areas. Now I will turn this back to Dr. Transu to talk about systems-level implementation pathways.
Thanks so much, Jenny. So Jenny talked through some of these pieces, but I think a lot of the challenge is you can get to a point where everybody thinks this is a really great idea. Of course, we should all be doing it, but actually making it happen is a real challenge, and that's why we focus so much on change management opportunities and really what this looks like from a systems perspective. And Jenny talked through some of the components of this slide, so I won't go through them in detail, but a few pieces that really are so important, really having those clinical and administrative champions. You can't do this work without having some people in your organization who deeply, deeply believe in it. Patient education and engagement is also really critical, and we want to look at how to increase the demand side of this as well as the supply side. This is something that patients should be able to expect and should be asking for. Sometimes clinicians are a little bit unsure of what patients want and have a feeling that people want to be told what to do. And really making sure that patients have that expectation of being engaged and of sharing in that decision. Knowledge and training, I think we've talked about, and action and implementation, and then always that accountability piece. I think we're all familiar with the Plan, Do, Study, Act cycle model, and we've all also probably experienced the Plan, Do, Regress pattern that has happened in some organizations that I've been in, and probably many of you. It takes a lot of work to get this started, but you also have to make sure that it really is continuing and that you've got ways to make sure that that continues to happen. Next slide. Some of the things to think about in an implementation process is really thinking about where shared decision-making should happen in the course of an episode of care. So to think about a procedure, if someone is thinking about a knee replacement, If they're at the surgeon's office scheduling the surgery, it's probably a little bit too late. If they've just had their first episode of knee pain, it's probably a little bit too early. Where should this happen? Who should be doing it? Who should be triggering it? So is this something that, say, the EMR gives a little notification of, oh, this person's been in a few times for this problem, maybe you should have a shared decision-making discussion? Could they be sent materials beforehand to review and come in and discuss with the doc after? Or is there a role for non-physician team members to be presenting the initial information and then the final discussion to happen with the doc? There's lots of right answers to this, and sometimes it should probably be happening more than once, early on, and then again, if somebody's getting close to the point of a decision. But you really have to think about how you're going to do that and when you're going to do that, who's going to do it in order to make it happen. Likewise, for cancer screening and certainly advanced care planning, many points in the process where it's appropriate to be bringing this in. So that needs to be thought about carefully in an implementation. Work streams and pathways, I think all of us who have been working in healthcare for a certain amount of time really understand that things will happen if there's a clear pathway and it's kind of easy to do. If it's too hard to do, it's not going to happen. That's just the reality of the number of things that both patients and providers are dealing with in the course of a day. So really figuring out how is this going to fit into care? What's the documentation? Do you have ways to make that easier? How is the process triggered? Facilitators and barriers, this connects back to a lot of the things we discussed earlier in terms of the importance of leadership, culture, champions. We've found that things that really help are having people who are passionate about it, having clear flows, having some kind of reward initially. Barriers, there are many. One of the most significant is what we talked about from the beginning, that people think it's already happening. Ironically, another big barrier is that providers really have the sense that this will take more time than normal care does. There are some really interesting studies suggesting that it actually doesn't. There's a lot of time that goes into developing the implementation, but once you're doing it, it actually doesn't take very long. And because patients do get their questions answered, rather than fumbling around the issue for a long time, you can really get to the heart of it very quickly. So that may be more of a barrier of perception than a barrier of actuality. Next slide. Ginny talked earlier about the stages of change and that kind of pre-contemplation, contemplation, preparation. I always think of this in terms of quitting smoking. Maybe you're not thinking about it. Maybe you are thinking about it. Maybe you've got a quit date. Maybe you've stopped and you're trying to figure out how to not fall back into it. Likewise, we really laid out in the recommendations different things that an organization should be thinking about at different stages. So if you really haven't been working towards your decision-making as a group, think about your mission, vision, and values, and really think about how shared decision-making could move those forward. Once you're into the contemplation phase, you want to be identifying those champions, thinking about training, selecting a framework. And then as you prepare to actually do a pilot or an implementation, there are a number of steps that you need to get in place. And I won't go through those in detail, but we can discuss more in the questions if people would like to. And on to the next slide. Preparation. Again, many, many components to that, and then there's actually putting it into place. Then the really critical point of maintenance, looking at how it's working, making sure that the model is working well and that people are really effectively using it and not slipping into shortcuts or not really staying with high fidelity to the model, and then spreading to other sites. Looking at what can make this more effective as time goes on. Next slide. Action steps for others. stakeholders, and we discussed this a lot in the work group, and I think this is really exciting, definitely in terms of patients and communities, the importance of really active engagement and empowerment. And this is a little harder for those of us who are used to working on the health system side to think about how to make this happen, but how can we get communities involved? How can we really shift the expectations around this? Providers and provider systems, I think we've talked through these ideas pretty well. So let's go on to the next slide. Some other stakeholders, insurers and employers really should be thinking about how to incorporate this into their health benefit structure, making sure that they're asking for it and requiring it, really supporting provider training and tools. Continuing to do shared decision making, as I said before, is not that time consuming, but training is time consuming and expensive. Shared decision making aids are something that has to be paid for. These are places where insurers and employers can really take an important role. And then working with health systems to reward this work and make sure that it's sustainable. Some other groups that aren't always thought about, malpractice carriers have a real stake in this because lawsuits go down when communication is better and when shared decision making happens. We have some very forward-looking malpractice carriers in this state who have supported training and implementation work for a number of provider groups, which is fantastic. And then professional organizations can also support training and education for providers. WSHA and WISMA, the Washington State Health Association and Medical Association, have done a lot of work specifically around advanced care planning and shared decision making in that area. So there are a lot of folks who have a stake in this, and we've worked in our recommendations to help elaborate some of the things that different people can be doing. On to the next slide. Ginny reviewed earlier the 10 topics that we picked. I think there's always a balance between not wanting to boil the ocean and at the same time feeling passionate about many different places that this work can be applied. So this was our compromise with these 10. Won't go through them in too much detail, but we really tried to cover a variety of areas. So as we mentioned, the surgical areas, the behavioral health, looking at a variety of ages where this could be impacted, thinking about advanced care planning again, since that's been a big focus in the state. And each of these has a place in the care stream, whether it's primary care that's doing this work, whether it's shifting more into some of the specialty work that's happening. Really, each of these impacts a different group of people. And one of our goals was to educate as many providers as possible about these methods and these techniques, because once somebody's using them in one area, the likelihood is high that that will also spread to the other conversations and those skills will be used elsewhere. We can talk more about all of these things, but I also want to make sure that we have time for questions. Let's go on to the next slide. So these are the places where our recommendations can be found. The Bree Collaborative Workgroup has recently released its recommendations for public comment, and we are extremely eager to get people's feedback on these. So please follow this link. We'll be sending out the slides, and look at our recommendations and let us know what you think. We're very eager for feedback, and we have a survey as well. On to the next slide. So Ginny, I don't know if you have anything else to say before we move on to questions.
Yeah, I would just encourage people to look at our reports and give us feedback. We really want to hear whether this is useful, whether these frameworks are useful, whether these 10 topic areas resonate with you. Are we missing any particular healthcare service about which you feel strongly? Let us know. And these are draft right now, and we will take your comments back to our work group and make changes. These are kind of living documents, and we want to make sure that they're representing the priorities of our Washington State healthcare community. Yeah. So would love to answer any questions that folks have.
Awesome. Thank you, Emily and Jenny, for presenting. That was very informative and interesting to hear about. And we do have one question from an attendee. You touched on this a little bit with the system implementation slide, I believe, but just going back to the patient engagement, is there a specific plan for patient and family engagement with a statewide shared decision-making implementation?
That is a fantastic question. And the short answer is no, we don't have a specific plan in place, but we would be really, really interested in getting people's input on what that might look like. I think there has been, up to this point, more study and understanding of the healthcare system side of how to do this. We've had some great community partners on our work group who've had some good ideas around this, but we would love to have more input. Jeannie, I don't know if you have anything to add to that.
Yeah, I think a lot of people might not know what shared decision making with a capital S really is, and sort of assume, like providers, that it's already happening, and that not necessarily see this in the framework of having a patient decision aid. So we want that all to feel normal. So you would be sent material to review prior to a visit, or receive it when you are talking to your provider. So we'd love to partner with different community organizations to kind of spread this common message of shared decision making. I think it's helpful for us to all talk about this in the same way, and we hope that the recommendations can be a start for that.
Okay, great. And then we just have a couple questions that came up as we were listening. One goes back to the exploring values piece that you talked about, which I think is really important as people are, have all different values and are trying to figure out what's going to be the best decision for them. Within the implementation frameworks that you talked about, is there a communication training available to guide a provider in that value conversation with their patient? Yeah.
There's a really great shared decision-making training that includes specifically a lot around that is available free of charge through the end of the year through the Healthcare Authority. We worked with a decision aid developer called HealthWise to develop this training, and that's where I would send folks for that. It really is a fantastic training. It's online and you can do it at your own pace. It's got some video examples and it's interactive. So that's where I would send people, and we could definitely send the information about that out to this group.
Perfect. Thanks, Emily. We can, you said you can send that over and we'll be able to share that to the attendees in the resources tomorrow?
Yeah,
okay, perfect. Awesome, thank you. So as providers are starting to use shared decision-making with their patients, are there ways that organizations or providers specifically are held accountable or, show proof that they're actually using these decision aids and participating in shared decision-making as it's been explained in this presentation?
That is such a great question. There are many layers to that, and I think that gets into accountability and metrics around performance, which is something else that you'll find a fair bit of in our recommendations, because we thought about these questions a lot. And I think you can think about sort of quantitatively, is it happening? And then there's the qualitative piece of how well is it happening? So the quantitative piece comes down really to documentation, and partly we've put in some recommendations around the parts that should be documented to really show that you did all of those components of the shared decision-making process, rather than just, yeah, sure, I shared the decision. The question of really qualitatively, how well did that work, is a more complicated one. And I think that the best measures for that are patient-reported outcomes, which is something that we're all trying to move more toward. But of course, they can be a little cumbersome to get, to really ask a patient, how well did you feel that you shared in that decision? Were you asked about your values? Did you really get a sense of what the different implications of the choice would be? There's some really good short questionnaires that have been developed to do that, and we're thinking about ways to incorporate those more often. For example, one of the places that we use shared decision-making at the Healthcare Authority is in our Centers of Excellence program for spine care and total joint replacement, and those use those kind of questionnaires to get to the sense of how well did this process work. There are some very sophisticated research implements that do that in the research studies, but really are probably not viable for folks who are not in a research setting. So it's a great question. We do have some tools and we're using those, but I think it'll also be an area of evolution as well. Because you want it to happen and you want it to happen well, and those are not the same.
And this is Jenny. I would just add that it can look different at different sites too. So we didn't want to be too prescriptive about how documentation happens. We give some examples from some of our member organizations, and really want this to be owned by the sites that are doing this. So allow some flexibility there.
Great, thank you for that. That was very insightful. We have another question from an attendee just asking if they can see examples of the approved patient decision aids that you talked about. Do you have those that you can send to me that I can share with the group and the resources tomorrow?
A harder question than I would like it to be. In terms of the certified aids, most of them are proprietary. And as you think about it, a lot of work goes into doing a full evidence review around this, figuring out how to present it, and that's an expensive process. So most of the patient decision aids that have been approved are proprietary, and we can get you information about what they are, but we can't actually show you the aid. However, there are some non-proprietary aids out there, and we can work on getting you some links to look at some good ones, even if it won't be the full list of the HCAC's certified aids.
Okay, yeah, I think whatever information you can share would just be helpful to pass along and have everyone kind of see what you're referring to, or kind of what it might look like.
Absolutely.
Yeah. And then, okay. So something that kind of came up on our end that might be touched on, we might be like jumping ahead to part 2 of this webinar series, but just interested to get kind of your insight on this. For some providers, it might be just a force of habit to recommend a treatment without considering the alternative options and not realizing that when doing this, there might be some implicit or cognitive bias going on. So do you have any advice for helping providers kind of recognize this tendency and then break that habit and lean more towards the shared decision-making conversation?
That's another fantastic question. I think one piece of that is the training. For just to use my personal experience, I mean, for me, it was really revealing to go through that and think more about where biases may come in that you're not aware of. So I think one piece is just in being aware of it, having that training to sort of help you explore those possible internal implicit biases. And another really key piece is that's where aids come in, because the decision aids really force you to work through all of the options, really trigger that discussion of the pros and cons of each, because I think people have a tendency to sort of gloss over a little bit what they think is not likely to be as relevant. We'll give providers credit. I think they're generally trying to do the right thing. But when you've got an objective aid there that's really presenting that information, then there's much less of an opportunity for the provider's leanings to come into it. Ginny, I don't know if you want to add anything. I'm hogging the space here a little bit, but.
Well, you have so much more experience actually doing this. I mean, I think that's completely accurate. Any other questions?
Okay, sorry. Go ahead.
I would just jump in since we have a pause. One of the really neat things about doing this work is working with providers around it. This is why most of us went to medical school or nursing school, or, really these are the kinds of interactions that give people joy and reward in their work. And I think so often in the course of the medical professional day, it's a little hard to do those things because there's so much on everybody's plate. But one of the thrilling things about this for me is it's the number of people who have kind of come forward to say, I was feeling really burnt out until I spent more time thinking in this way, and that's been really helpful to me. So I would just call that out. This is exciting stuff for providers as well as for patients.
Okay. I just have one final question as a follow-up from our attendee regarding the patient-family engagement piece and the statewide shared decision-making implementation. What would be a chance to create some patient-family educational materials on shared decision-making?
Well, we'd love to partner with organizations kind of using the language that we've settled on and some of the images we've used to develop materials to send out to people. We've done this in the past with some other community organizations. I think it's worked really well and been really powerful. So we'd love to connect with whomever that person is and maybe think about some other organizations with whom we can partner too.
Awesome, thanks, Jenny. Yeah, the Patient Safety Coalition can help make that connection and facilitate that conversation as well. So we will link you guys up after this is over. But yeah, so I think unless anyone attending has any last minute questions, I think we are finished just a few minutes early. But I just want to thank today's speakers for sharing your wisdom with us and the rest of you for attending this webinar. As a reminder, if you are seeking CNE hours, please remember to fill out your feedback survey contained in tomorrow's follow-up email. And thank you all again and enjoy the rest of your week.
Thank you.
Thanks so much. It's really been a pleasure. And do feel free to reach out and please read the recommendations and send us comments.
Perfect. Thank you. Bye.